along into approval of the past EMCC minutes. Hopefully everybody had a chance to read it in the packet that was sent out.
Move approval of the January 8th, 2020 EMCC meeting.
All right, we have a second?
I'll second.
All right. So we are going to reshuffle the agenda just slightly. I think everybody remembers Dr. Grover from Prescribe Safe, who gave us an update.
I'm sorry,
Yeah.
vote.
For a vote to, oh, sure, okay, yeah, is there a vote for approval? All right.
Aye.
So then we'll move on to Dr. Grover. He's got another update for us today, so go ahead, you have the floor.
Okay, cool. I'm going to stand up just because everybody's facing this direction. So thanks again for having me. I apologize I missed the first meeting. I thought I could make it here and my appointment ran long. So we're going to take a deep breath and leave COVID behind. Everybody, deep cleansing breath. And fentanyl is still a problem. So I've been at a lot of the high schools recently, and overdoses are still happening. I don't have confirmed data, but my understanding is there were 2 recent teenage deaths in Salinas presumed to be from fentanyl. As a reminder, fentanyl is an ultra-potent opioid. It's in all of our illicit drugs right now, and our opioid overdose death rate from 2018 to 2019 quadrupled. So I was at the County Board of Supervisors yesterday. It was very funny. They kept pulling Mary Adams out, and I couldn't figure out why, and now we all know. But we actually trained the County Board of Supervisors on how to administer naloxone or Narcan, and we're going to get them some boxes to have in their offices so their constituents can actually pick some up, okay? And the idea, as you all know in this room, that naloxone or Narcan is basically the emergency medication for an opioid reversal. And as it pertains to our homes and families, it's almost like a fire extinguisher, right? I'm a very good driver, so I'm not going to wear my seatbelt home from Salinas. Just as much as if I have an opioid in my home or I live in a neighborhood or I'm a person that goes to Costco, an overdose can happen anywhere, even to good people, and we should prepare ourselves. So putting that all together as it pertains to this particular committee, we had spoken the last time we were here, and Dr. Close sends her apology. She's working a shift in the ER. That we'd like to develop something where if any first responder goes to a scene and there is an overdose, they can actually leave a dose of naloxone behind for the family, since unfortunately opioid overdoses tend to recur, whether it's a particular area or it's a particular person who is addicted to opioids. And the other part of it, on the flip side, is I heard from somebody yesterday that they're a first responder and they're so frustrated that somebody's overdosed twice in 24 hours and they have to keep saving that person. So Dr. Close drafted up, and I don't know if it got sent out, basically a double-sided sheet to give to people with every resource for drug treatment in the county. And I can tell you that Natividad, I heard yesterday, has already started taking people off of whatever opiate they're on and getting them onto drug treatments for opiates like Suboxone, and they've already successfully treated 60 people. Sean, do you have your X waiver?
I do.
Michelle, do you?
Yeah.
Excellent. So at CHOMP now, I believe we have 13 or 14 doctors that if somebody's a heroin addict or a pill addict, we can take them and get them onto a medicine called Suboxone, which is much less risky for overdose. So the idea is that an overdose isn't just an event, it's a trigger to get people into treatment, and then with your help, we can try to prevent further overdoses and arm families to be able to prevent overdoses in the future. Hopefully that was a pretty succinct overview. Any questions, suggestions? Yes, sir.
I have a question more from a local jurisdictional. So we've encountered a number of situations that we're suspecting may be fentanyl related. How or should we be notifying your group so that you have that data and can do good things with it?
So there's a couple of kind of layers to that. We did speak also last time about a program called OD Maps. So what that is that's federal, I think, law enforcement put together an app that basically, or not an app, it's a web-based server that allows first responders to log an overdose. As I understand it, the entire agency cannot do it. Please correct me if I'm wrong. But if an agency wants to participate, they can literally on scene log an overdose to be suspected fentanyl. Alternatively, I'll give you my email. You can contact me directly. And if it's a fatal overdose, then the coroners will obviously test that, and then that'll come back, though there is a bit of a delay there. But I think just information sharing is important forgive the analogy, but just as much as the coronavirus, we're all trying to share what we know. This is the same sort of problem, whereas last July, we didn't have fentanyl the way we do, and it really hit us hard in October. We've been trying to share information as best we can. Yes, sir.
Casey, could you share with us the outreach to the media? I think there's been at least one interview, if I'm not mistaken, with your wife by KSBW. It seems to me that part of this lends itself, the thrust of this lends itself to media outreach and communications with the community.
Absolutely. So the initial kind of sentinel event was a 16-year-old who died in October. Her name was Perla. Her family has really advocated for this sort of work. We saw them this weekend. They're very nice. They want us to get the word out. That's why I use her name. They've asked me to do that. After her death, we had in that, I think like the next 9 days, I think we had 9 fatal or near fatal overdoses just as well. And I heard similar instances in the Salinas emergency departments. We had, I think every news media in the county had some sort of story after that. The Weekly is putting together a story on this as well. And periodically we do get news or coverage, whether it's from the Weekly, KSBW, they have their State of Addiction series, and you are correct. Yesterday at the County Board of Supervisors, we presented fentanyl and then showed a training video on how to administer the reversal agent, naloxone. And chair of the supervisors, Supervisor Lopez, is going to basically create a little video that they can link to in each of their offices so that if folks are interested, they can learn. We've also, and I didn't bring them, I'm so sorry, but we have tip cards for after an overdose. So I think the idea was, and I learned this from law enforcement, that people don't want to give a tip about where they got it from, and it's hard to track. And people are also afraid that, you know, if I've got a party and my friend ODs, I'm not going to call 911 because I don't want to get in trouble. And there's a Good Samaritan law. So CSUMB put together little refrigerator magnets for their students of please call 911 in an overdose, and then they list the Good Samaritan law. And my hospital put out cards with like tip lines for the sheriff's office and Monterey PD that we can also give out, and we have hundreds of those to be able to say, at the scene of an overdose, here's what happened. And then I'm giving also my social worker those who does outreach with Monterey PD.
Thank you.
Might I suggest too, when you go back to your jurisdictions or your cities, I know we created that Overdose Life-Saving Award.
Mm-hmm.
And so when we give the award, we send out a press release and we actually link it to your information regarding it. And the media, and why we link it, because that's the human interest part of it, right, when you're branding stuff. And they will run it. So they've run press releases and repeated the information that's there. But I think it takes a village, and we all have to keep hitting them with these press releases and not just rely that you guys are going to do it. So.
Right, and additionally, I think the most at-risk population right now are our students. So I was at Monterey High Monday. I gave 3 lectures. I was at PG High last month. I'll be at Carmel High next month. I was at Central Coast High, Rancho Cielo, PG Community High. We're also trying to create a message for the students, and we were also introduced to Dr. Gus from the Board of Education to be able to craft kind of a message for students, because that's really, I think, what we're seeing the most high risk right now. I mean, it's funny, I went out to Rancho Cielo, which I didn't know was the continuation school for Salinas, and the kids were like, hey doc, I get it. You got that fake Xanax, you just break it. If it doesn't break right, you know it's counterfeit. And I was just like, I didn't realize that level of sophistication and that level of confidence in their ability to detect counterfeit. Because as I understand it, most of our street pills have at least a good chance or are fentanyl. And what's amazing, and I may have said this last time, but the fentanyl isn't equally distributed. So we've seen kids at CSUMB that smoked a half pill and end up apneic and require bagging and Narcan because the fentanyl may be distributed on one half of the pill and not the other. Or if you get a test kit for fentanyl and you scrape off a little bit, that might test negative for fentanyl because the fentanyl is unevenly distributed through the pill. So that's the message I'm delivering to students. So I apologize, I've been a little distracted with all the other things that we're all preparing for. Do we have a policy that is going to be rolled out, or how best can we support?
And this is where we move next to the.
Sure, yes.
that
So
item.
we're
So
currently
yes, thank
on
you.
old business. So
Thank you.
go ahead.
Yes, so the item number under old business, the
Yeah.
opioid.
The opioid overdose.
Mhm.
We need to keep it in the media forefront too.
Second.
You know, try to get
Tom,
more
will it?
PSA.
I think they want you to go out. Okay. All right, so I guess I'll go out of here. Very good. Do you want me to stay up or?
Right
Odyssey.
there is good, yeah, absolutely. Thank you, Doctor, by the way, for bringing that information to us. As the doctor has stated, Dr. Burley and I have been working to provide a program for naloxone leave behind. It's a similar project that San Francisco EMS is currently involved in. And it's to, because we in this county are also experiencing an increase in opiate-based narcotic overdoses. When people really started reacting in our county specifically was because of the unfortunate incident with the 16-year-old girl in Seaside. So the EMS agency, along with our other community partners and resources, began to research ways to assist those who experienced an emergency overdose event in the pre-hospital setting. In the last meeting that was conducted, it has been received very well by our system provider agencies. And if we are seeking approval from the EMCC, an endorsement, if you will, to move ahead with this program, I believe that the policy and the notes for the policy have been posted. If we seek the endorsement of this committee, we will then move forward to the state EMS agency with an application to go ahead and expand our local optional scope of practice to provide the naloxone leave behind with the folks at Prescribe Safe. And I wanted to give Dr. Burley an opportunity to comment further on this as well.
Yeah, thanks, Tom. And we talked about this at MAC just an hour or two ago, but essentially we want to just recognize the passion with which you and Dr. Close addressed this issue, and the presentation that you gave to us last time we met here. It was moving and prescient, and I think it really instilled on us how much of a crisis this is, and the opportunity that we have as a community, as an agency, as providers, to make a big difference in saving the lives of people who overdose on narcotics. And some of those people are not necessarily the people you would expect. Some of those people are young people who are doing this for the first time. And so I think, from the agency standpoint, we have been working hard on putting this into practice. Obviously, there's many things, many ducks to get into a row, but we've gathered our ducks, and we're excited to be bringing this policy before this group and asking for approval from EMCC standpoint, in which we would be able to move forward with a naloxone left behind policy for patients who EMS gets called to the scene and ends up having to resuscitate the patient, but unfortunately the patient then decides to sign out against medical advice. And we've built into the policy other opportunities as well, such as you run a call for a patient who's on a lot of narcotics and she didn't necessarily overdose, but you recognize the potential for that. And so I think there's a lot of opportunity here to save lives.
And I know in the last committee there was a question about folks coming up to the ambulance, knocking on the door, and safety concerns essentially. Currently, to date, there are no reports of any safety concerns to first responders or ambulance providers that are people are trying to obtain this Narcan from EMS crews in any way, shape, or form. So believe that the program is safe, and all of us within the EMS agency have been working together to come up with this policy, and again, seeking the endorsement of this committee. And I'll take questions if you have any.
Chair, I would like to make a motion to the effect that the EMCC endorse and recommend approval of this policy, subject to any final refinements to be made by the EMSA agency.
A second?
All in favor?
Aye.
Any other questions regarding the opioid overdose?
I really want to thank you for being here.
Yes.
I know your and Dr. Close's schedules are super, super hectic, so.
We're all busy.
Thank you.
Okay, so we're currently under item 6, and I appreciate the leeway in adjusting the agenda a little bit, but maybe we'll go on to B, the RFP update, Teresa.
Reports? Are we going back to reports?
Well, let's finish old business since we started.
Oh, I'm sorry. Oh. Thank you. I don't have a whole lot to report. We did lose a little bit of traction, but we have gotten back on track. In terms of timeline, I think that by in the next couple of weeks, the RFP should be going to be translated and then released for public comment. Other than that, I don't have any more concrete timeline at this point.
So we're saying at this point that we could possibly see the RFP available for public comment in, what, 3 or 4 weeks?
A third or 4 week of April.
April, okay. All right, well,
And we are watching the timeline carefully to make sure that we are, we don't run into any problems during the RFP process.
Okay, the other side of the coin here is how long a period will be available for public comment?
One of the requests that we saw here is that, a minimum of 30 days.
30 days?
30 to 45 days, but we'll take a look at that. We're working with, under the guidance of contract purchasing and county council on that.
Depending on the complexity of the RFP, that could be a relatively short time.
And the timing can be adjusted. Like I said, we have built some cushion there.
what steps are going to be taken to advertise for public comment?
Well, traditionally, we've done newspaper, we've done social media, we've done radio. Looking back at my previous life in environmental health, one of the ways that we got notices to the members of the public, it was a mass mailing by the post office, and notices went out to every single resident in the county. So we're looking at doing that as well. And of course, it's going to be posted on the website and sent to different groups that may be interested. And we welcome ideas.
Okay, thank you, Teresa. Any other concern for the RFP at this point? If not, then we'll return to the top of the agenda. Item 4, reports. We have a report from the Medical Advisory Committee. Anybody?
It's just the minutes.
Yeah,
The minutes
just
were
the
attached.
minutes, yeah,
Minutes,
okay. So moving on to B, EMS agency.
Thank you. Some of the updates that we have is we submitted our STEMI and stroke plans, and they were approved by the state. Thank you, Laura, and everybody who worked on those plans. Coming back to the OD maps, I wanted to circle back with the group. We had received, following the January meeting, we received a request to see the EMS agency could issue a policy requiring that people in the field use OD maps to report the incidence of overdoses. But unfortunately, the EMS agency cannot require participants to use any particular software in the same way that we could when we put together the ESO countywide data system. We could not require everybody to join ESO, but as long as they had a system that seamlessly integrated to ESO, in the same way we cannot require everybody to sign up. We have looked at the OD maps. We know that it is HIPAA compliant. Anybody who wants to participate would have to sign an agreement. It is sort of a data sharing agreement with OD maps. So it is something that I think each individual agency, which is, I think it speaks to your question earlier, that each agency would have to look into, you know, whether or not they would want to participate. Two issues they were discussed at this committee that we wanted to make sure that we circle back on. There was a report to the agency that of a concern that after the implementation of the MPDS, that we might have been sending ambulances to every domestic violence call. Jared was able to work with our folks and monitor the calls, and we were able to confirm that we are not being, the units are not being dispatched unless it is confirmed that that medical assistance is needed. And similar with lift assist, the units are being dispatched when the call comes in, but as they do in the EMD process, as soon as they find out that the call is not a medical call, then the unit is canceled. I think those are my updates for now. Any questions? Thank you.
Okay, so Jared, we'll invite you for contract compliance work group.
Okay, switching gears here, good morning. The contract compliance work group continues to meet and review the compliance of the provider. We kind of did a summary for 2019. It's very similar to what you've seen before, but we have added some annual summaries to mutual aid, some dispatch stuff, as well as some of the response priority compliance. So first slide here, you can see 2019 system volume, and it's just a pie chart representing system versus all call volume, including IFT. And I cannot read that, but I think that's to the left is the total call volume, including IFT, and the one on the right is system calls, which would be your priority 1, 2s, and 3s.
Right.
There we go. Thank you.
Is that better for you?
Yes. Getting blind. So you can see the, you know, in typical organic, you know, growth in these EMS systems, the volume typically continues to go up every year. So we've seen that here too. Mutual aid, they report both provided and received mutual aid, and that's indicated under 2019 by provider and the volume, and by quarter. And this is mutual aid received into the EOA. Mutual aid provided, AMR also provides mutual aid into areas within the county and outside into Santa Cruz and San Benito as well. And that's a reflective summary of 2019 for AMR. If anybody has any questions, go ahead and just, you know, I've been.
May I make a quick
Sure.
comment? Thank you for that information, and just for what it's worth, when I viewed that data, to me that reemphasized the need for mutual aid. So as we move forward with the contract, I just publicly want to state that I think our data supports the importance of mutual aid amongst organizations, because it results in cost-effective ways to ensure and service improvements to the patients that we treat. So I just wanted to thank you for doing that and state that I think that reinforces that need. Thank you.
I think mutual aid is here to stay. Yeah, it has to be.
This next slide is the representation of transport volume, how many responses end up in a transport, and it's the average is 67% of all calls that result in a response actually result in a transport. There's many reasons for this, and we look at it for efficiency reasons and how we can improve the system and look for you know, key performance indicators that might be needed to be addressed. So that's one of the things we look at as well.
Yeah,
Does the patient have to pay anything for a non-transport?
I'm sorry?
Does the patient have to pay anything
No.
for a non-transport?
No, there's no payment, no charge.
I think the thing that strikes me here, or struck me here when we first looked at this, was the consistency of the 67%. It varies a little bit, but generally speaking, it's about the same. And also the volume of calls overall is about the same. I don't know whether that's significant or whether that's going to change, particularly with growth. But I think it's the fact that it's relatively consistent across the board just surprised me.
Well, it's indicative of how this system works,
Yes.
and all systems are a little bit different. And there's reasons why non-transports happen. Sometimes it's just, that's the way it works. But what we try to look at is how efficient is our system. The call intake side can be very huge to affect this, and are we responding appropriately, et cetera. So not a whole lot of analysis this year based on that, but the information of where we stand.
It would seem from an operational and a managerial standpoint that we want to eventually, it would be desirable to reduce the non-transports. And that caused me to sit there and think, how can we do that? I don't have an answer for that one yet.
Yeah, a lot of it is just, you cannot change the callers who request help, but you can provide the EMD and the triage to lower response or perhaps even non-responses in the future with referrals and stuff like that.
Right.
A lot of that segment of non-transport would normally fall in your alpha non-referral type call if we had a system like that where, hey, call your doctor or something like that.
I think over a period of time, it's not going to happen overnight, but EMD may have an effect on that. We need to look at that to see if in fact it does. I mean, that'll evaluate the quality of our EMD.
Yeah, we've seen a slight increase of non-transport because of lift assists.
Yes. Okay.
So how that's being processed initially by the call taker, which is the county, is not being EMD. So we're getting a lot of non-transports from that and other calls that are not properly processed. So I think I wouldn't say properly. They're just doing what they did since they did it in the 1970s. It's
Right.
still happening there.
That's a good point. We did make substantial response policy changes towards the end of the year. That's part of why we're not reporting a lot of analysis, because we can't tell what has affected what yet, but we're in that analysis phase with the provider and contract compliance to determine what tweaks need to be made, if any, how did it affect the system, et cetera. So
Over a year,
as the months go on, we'll have
over the
that.
next year, I think
Yes.
we should be looking at any trends that may develop.
Yeah.
And Tino's point is well taken.
And you'll see some of the compliance effects on the next couple slides.
Okay.
I'm sorry.
Another quick question.
Sure.
In other counties, will insurance companies or Medicare reimburse the cost of a non-transport?
Well, there is, CMS is rolling out a 5-year pilot called the ET3. I'm sure many of you know about it. And participating providers and LEMSAs can develop policies for that. We're not there yet, but those are, discussions, and some of the other systems might be doing that.
Do you know offhand statewide, as you guys talk to a lot of the other counties, is there any other counties where they get reimbursed for
They're all-
non-transport costs?
I don't think so. They're all pilot programs right now.
Okay, thank you.
Yeah. This next slide is an overall roll-up of all the compliance by month for the year 2019. You see a couple of the red, less than 90% represent the priority ones, which are the highest priority. Again, remember between September and November we made those changes, and that affected the volume of priority ones to priority twos, and that's the stuff what we talked about that we're going to be evaluating as to how it impacted the system. So what those numbers mean, it's kind of hard to tell right now based on looking at only 3 months or 2.5 months of real data, but that is something the contract compliance work group is really interested in, and with Roxanne's help, determining an analysis of how that impacted us. So, but that's where we are now. You can see in all other priorities, the compliance went up. But again, the shifting of most of those other priorities into a priority 2 kind of left the priority 1 bucket a lot less. It's still substantial enough to report because it's about 200 a month, but it went from 1,700 a month to 200. So we're looking at that. And this is broken down by response area. There are 4 response areas. The green is the 8-minute response area for priority 1. This is the, metropolitan, the higher density areas. And then yellow is historically been difficult to serve, and we're peeling apart as to why, and seeing how the effects of our policies will or will not affect historic performance. But you can see in priority ones, and sometimes in priority twos, the provider has struggled to meet the 90% in the yellow area. Yellow area represents more of a suburban, rural-ish area based on population density. And a lot of that is North County and South County. And so it's a big area to serve with, sporadic call volume, and that's part of the problem. But again, because of the policy changes at the end of the year, we're going to provide some analysis as we go as to how that impacted it. Orange, even more rural, and that's why you won't see a whole lot of data, because it takes a while to get to that 100 call rule to be able to report anything. But what we have seen in October and December in the priority twos is a very high compliance. We haven't had enough data in priority ones in orange to even report yet, so we'll provide that when it hits that mark. Dispatch use, this is a great slide, and Harry wanted to display this. We talked about the 50% for the amount of calls that actually receive the medical priority dispatch system. We made the policy changes, and you can see November and December was about a 13% increase in calls going through medical priority dispatch. Some of those are non-medical calls, and we'll be carving that out for further analysis to report as well. But a lot of them are calls that were originally screened out for other various reasons. EMD performance, this is just by contract, they need to assign a resource to a call in less than 59 seconds. They've never had an issue with that, and that's reflected very consistent over the years. These are just data definitions. We don't need to go into those unless anybody has any questions.
Jerry, just going back to the yellow area and the priority one response, just speaking from my jurisdiction, but thinking about how a lot of the designations of the different zones are geographic. I just wonder if, in your looking through your data, if you could separate highly densely populated areas within the yellow zone. So, for instance, the city of Greenfield, Soledad, and other similar South County cities have a high density population within a small area, but yet they're in the yellow zone. And I'm just wondering what the response is as a priority, from a priority standpoint, within those pockets within it. And I think that might be the answer to your question, possibly, that, and I'm not trying to push anything from a political standpoint, but just more from a logical standpoint, that I wonder if those highly densely populated areas skew your data because you're comparing that to a more rural area where it's not as densely populated.
Very likely, these maps are, were done 12 years ago. That predates most of us that were here, so I can't even speak to the methodology, to be honest. We've done some research to try to figure that out, and we've done some looking at this, and Roxanne has helped as well to improve the maps, moving forward. This is the way it is now. This is under contract and how they were built, but that is part of the problem. Is you have a designated, higher response time to some very rural areas. And so, that's kind of the result, I think, for the most part.
I'll just kind of leave it with, I know AMR Clark County in Washington, the criteria that they used for their different prioritization was they used the population density, and the population density was based off of 1,000 people within a per square mile, which is what designated, urban, suburban, and rural. And just kind of going back to what I said, I think that kind of helps skew that. I don't know if that might be a way of looking at it differently.
Yeah, and there are methodologies like that. The problem is there's no standard, right? So you go to another system and they might say, 0 to 500 and is green, 0 to 1,000 is green. So it's hard to kind of do an apples to apples with so many different systems. So, we want to be able to strike the right balance too. If we're, we want to be able to create a response methodology that is possible to attain as well. So those are all, considerations we are looking at. But these are based on, the 12-year contract that the maps were already set in stone. So we're just evaluating based on, what they're required to do based on that. Any other questions on the compliance side?
Yeah, those of us on the contract compliance work group have been advocating for several months to have regular updates, so it's good to hear some of the other comments. Hopefully the data that's presented is useful. Thanks, Jared.
Mm-hmm.
So I guess we'll have you again for the EMS system performance.
Okay. There you go. This is a standing report. Anybody has any questions? I know you've seen it before. This is just a readiness drills that we do every day on the radio and through ReadyNet with the hospitals, and AMR initiates those tests. Again, relatively high compliance, a little bit up and down every now and then, but within 90–95%, all the hospitals are performing well. What I would like to mention briefly too is that over the last couple weeks with the Princess Cruise assignment and some of these other COVID issues that we'll be talking about, we have upped the ante and required bed polls daily for the hospitals. They normally put those things in themselves, but this was specifically related to, hey, the region 2 needs to know how many negative isolation rooms you have. Please respond. And all the and we report that data up through the chain, so the state knows, the region knows. And one very positive thing is, as a result of this, is that all the hospitals are very responsive to it, and it's great to see how the use of ReadyNet is expanded in these types of events. So kudos to the hospitals for that as well, and providing the data, knowing that they may get patients. Not yet. But. Any questions on those? Okay.
All right, yeah, ambulance offload times.
Going back to where it shows the impact time, since it can see some package, don't have to play it. Just past Jared's presentation. Just past. Nope, don't.
Keep going.
Oh, you just about had it. Nope, keep going. There.
All right, there you go.
Okay, thank you. I figured. We report our ambulance patient offload times to the state on a quarterly basis. So this is quarter 4 data. The first one here shows the number of transports by hospital. And then if you scroll down one page, this shows the APOT time at each hospital by month. These are 90th percentile times, and they range anywhere from, we have 7.5 minutes up to 21 minutes. And that reflects the number of patients that actually are going to these hospitals as well. But the take home from this is we don't have an APOT time problem here. There are a few outliers, but they are outliers, and this shows that the hospitals and everybody is doing a really, really good job at keeping these to a minimum. So we will continue to send these to the state and to report to this group. Are there any questions? Yeah.
Is this just AMR or is this all transport?
It's all transporting units. Yeah, I pulled the data off of ESO. ESO has a canned report on this, and that's when I actually do completely trust the data, because only the transport units are the ones who are going to have APOT times at all. Yes.
Can you comment, I've never asked this, but I know this is a problem in other jurisdictions. I just was wondering if it's been here. Are there any issues with ambulances transporting to a hospital that's open, but they have no beds available, and so then the patient stays on the journey for extended periods of time?
That's exactly what NAPOT time is.
No, I know that, but this is this current month. I was kind of looking for a long-term history. Has that been a problem in the county, or do we just?
No, we actually just started measuring this when the state was requiring, actually, that's the first reports that I've been giving on these. But to my knowledge, we have not ever had a problem with this. I came from Riverside County, and these numbers, they number in the thousands of hours.
Okay,
every
so
quarter.
hypothetically, if we did have that situation, do we have a protocol in place for an AMR supervisor or somebody to go to the hospital, talk to the charge nurse or whatever to kind of get things moving so we
We
can get
don't
that ambulance
have-
back in service?
We do not have a protocol in place, but certainly that would be the expectation. To go to my experience in Riverside is supervisor needs to go to the hospital and just be the squeaky wheel. Because hospitals need to, traditionally and typically, they look at who's the most serious. So the ambulance might have an unconscious drunk on their gurney who is breathing fine, everything's fine, he's just drunk. And then they have a patient in the waiting room who's vomiting. And so clearly the patient is vomiting. It's probably more critical than the unconscious drunk. But what you have to look at is that, yeah, this guy is not terribly serious, but the guy out there waiting for an ambulance may be. So we'll have to, the hospitals kind of have to think more operationally.
Operationally, from AMR side, we've implemented mechanisms in the last 3 years, even prior, to notify our supervisors with CAT pages and even phone calls that a crew's now delayed at a hospital for an extended period of time. Once we start seeing an ambulance stack more than 30 or 45 minutes, the supervisor is asked to either contact the crew or go directly to the hospital to make contact with the charge nurse. Historically, the hospital's been really good, but now with more demands from our system, a change in priorities, we are now encouraging and actually telling our supervisors you need to go to the hospitals directly and make contact. And sometimes we find out our crews are finishing up or can clear, or we find out they really are sitting there and stacking. So AMR has taken that initiative. It's not in the county policy, but we've taken the lead on that just to ensure that the system is maintained with solid integrity when it comes to that. So supervisors are 24/7, but these guys are usually up more than that trying to make this happen.
And if that doesn't provide resolution, we have our duty officer that you can always contact the duty officer, and they can contact the hospital, get some situational awareness, see what we can do.
I think Gary's point is well taken, and I think what I would add to that there are systems in this nation that actually do have a problem with this, and they literally, the ambulance provider literally hires a paramedic to staff the hallways as they're waiting to offload patients to get their units back into service. But the bottom line with it is that it's a system issue that can lead to other alternative programs like MIH or BLS transport capabilities and that type of thing. But going back to Gary's point, looking at this from an EMS system and having things in place so that we're more responsive to any potential problems as opposed to reactive may help us in the long run.
I can make a comment on that. I totally agree with you. The reason the contract compliance working group looks at us so closely and has for a long time is we want nothing to impede that getting that ambulance back into operation, get it out of there and get it back. So you know, we've looked at the consistency and any variances in that across. We meet every other month, so that will be continued to be monitored. I assure you that's high on our priorities, even though it's not a problem here in the county, Jerry. So it's high up there.
What I'm saying is more than just monitoring, maybe predicting and planning ahead so that we're prepared if and when that ever does become a problem.
Yeah, if it becomes a problem, we're going to yell.
Well, my secondary point, Chief and Harold, was really, I don't necessarily think that it's good policy to wait until it becomes a problem to do the planning and preparing, and that it might be wise for us to be proactive and have a protocol in place now before we have a problem, because as EMS systems, and ours is going to be no exception, continue to be stressed And this may become an issue here in the future, and if we already have something in place, that's probably a better system than waiting until there's a problem to react to it.
Okay, thanks. All right, so moving on to item 7 then, new business. I guess Jared, you have an update on COVID for us.
Yes. So the original intent of the memo was to just try to outline some of the steps the EMS agency has taken to address the COVID situation here locally. I'm just going to highlight, a couple things, and then if anybody has any questions, feel free to engage. Back in February, the EMS agency implemented the emerging infectious disease tool at MPDS, which allows the dispatchers to ask a couple of questions that are medically director approved. So, and those can change on the spot based on how the situation evolves. Travel was a concern in the beginning. That's probably going to be less and less of an issue as things continue. So with Dr. Burley and Dr. Moreno, they approved the questions, and they asked them and provide that information to the crew. The way it works is that, the information is what it is. Whatever the information is gets sent to the crew. If it's one of those, travel related questions to one of the level 2 or 3 CDC designated locations in the world, that's obviously higher potential information. The information is available in the CAD, but is also alerted to the crew if it hits that trigger mark of, the patient has traveled in the last 30 days to, this country or whatever. We've had a couple scenarios where that's worked, and in every case so far it's worked the way it's designed. The information went to the first responders, it went to the crew responding, and the crew notified the ED prior to transport or prior to arrival. So that is the main purpose for this, is just to give a little extra awareness as to what's going on, so that, maybe don PPE before you get into the house, or keep some people out to do an assessment, and providers can make those determinations, and then provide more information once they do a primary assessment in person to the ED as well. We've sent memos. Most of our guidance will be directly related to CDC latest guidelines in pre-hospital clinical care, infection control, and decon, or CDPH. And those have updated, and we try to communicate to the stakeholders of all of those updates. We realize that our first emergency here in this county will probably be the lack of equipment. So last week we did an assessment, or sent to all the providers, including law, first responders, anyone who might in the pre-hospital environment come in contact with a patient, and ask for any supply chain delivery issues, and to try to be as specific as possible so that we could try to help. So through the Mohawk program and others, there's ways to procure local and state equipment as needed. And right now it's pretty much the surgical masks and the gowns and the N95s. So we have had some responses and some needs already placed, and we're working locally and if needed to the state to get those supplies to the providers that need them to bridge that gap. So you will probably see this as a weekly thing, because things are changing so fast. So we'll probably ask for an assessment by the providers every week. So apologize for all the work, but it is important, for us to know kind of system-wide where we are as far as that is, so that we can try to provide whatever assistance we can as far as that extra equipment. The health department stood up their DOC, I believe today, as their first operational period for a week. The Mohawk is a function of under the operations, so we will be involved with that and be working on the objectives that they approved yesterday, mostly related to PPE procurement for the first responder and others. So probably more information as the DOC continues to operate and work on those objectives and things change. So I don't know if anybody had any questions.
I have a quick question. Has EMSA looked at any protocols or policies that we can technically treat and animate these people at their houses, so we're not transporting them or taking them to EDs where they don't need to be?
We haven't engaged in policies yet, but that is one of the recommendations from CDC and CDPH is that they don't necessarily need to be transported, and it may be better off that they're left at home under, you know, self-quarantine conditions, and Dr. Brody can speak more to that, but that's definitely something that the responders should consider. If you've got a healthy, aged person who is sick, but you know, maybe it's just better for them to stay home. I don't know if you can elaborate on that. But.
Yeah, I mean, I think that's a very good point and something that we should be looking at as a system. Alternatives to being transported to the emergency department for every call. Certainly, it's the purview of EMS providers on the scene. If they get to the scene and the patient, in their judgment, doesn't need to go to the emergency department, they can have a conversation with the patient and say, this is what I'm seeing. This is what you can expect if you do go to the emergency department. In other words, none of the ERs are testing at this point. You're not just going to run to the emergency department, get a quick test, confirm that you're negative, and then go home. Let's not go to the ER with that expectation in mind. There are some labs that are doing outpatient testing, like Quest, and so we're starting to sort of brainstorm a little bit as far as, can we get kits to people so that they can, you know, do a self-swab, submit it to an outpatient lab, and get a result back within, you know, a 72-hour period. So this is not something that we have a policy on yet, but these are some ideas that we're considering to sort of limit patient exposures for themselves, and also in the case that they are positive, to limit the exposures to other patients in the emergency department. So I think that's something that definitely is important to consider, and providers can feel comfortable having that conversation with patients, and if patients don't need to go to the ER, it's probably better that they don't. Now, we don't, you know, if a patient wants to go to the emergency department, then, you know, we should be transporting them. So we don't want to tell people, no, we're not taking you. But you know, I think an intelligent conversation can go a long way.
Policy would really help with that, though.
Yeah. Well, there's, you know, the state has issued some guidelines regarding that as well, and I had sent a copy of the letter to Jared. I think he had distributed it to the chiefs and some and other stakeholders, and that you know, we certainly have precedent for this, and it's appropriate for providers to have that conversation. So you have the backing not only from the EMS agency, but from the state's perspective in that regard.
Another conversation, and I don't know, you know, where we are with it. We're in the discussion stages. Is the alternative destination piece that might down the road be important? The state has already relaxed those rules, and that's something we can consider. So, like I said, as this kind of, you know, that might be something to think about that we're already discussing inside.
On the other end of the spectrum, we had, you know, discussion at MAC regarding treatments that can put providers and other patients at higher risk of transmission, specifically anything that sort of propels droplets, or, you know, the patient's exhalations to be sort of cast out into the local environment. So things like CPAP, certainly like aerosolized, nebulized treatments, all increase the risk of transmission in a positive patient. So in general, if you know, either the patient's going to be very well looking, in which case they probably don't need to go to the ER, or if they're very sick and need respiratory support, things like LMAs or intubation are safer than putting a patient on CPAP. And the hospitals have requested, you know, specifically that if you don't need to give a patient a nebulized treatment, please refrain from you know, bringing patients into the emergency department on neb treatments unless it's absolutely critical that they get those for respiratory support. But those are some of the guidelines that have been extended.
And I think the other one was DCing the treatment prior to taking the patient into the ED if you are. So is another good precaution.
Do we know how many respirators we have in the county?
Respirators, not offhand, but that's part of the
That's
polling.
something we should be aware of, though.
Jared, I don't have trouble grasping this one, but you haven't touched on any training issues or any equipment issues yet that would be, that could be solved from a common core from the county level. Have any been identified so far?
We largely pushed that down to the provider level and you know, given them guidelines to do their own training based on what the CDC and California Department of Public Health have issued. I think the discussion on whether we escalate to a change in policy or a temporary protocol change or things like that are off, you know, things that are on the table, of course. I just don't know that we, you know, need to pull that trigger yet, I guess.
Okay. What about equipment?
Equipment part of that is through the Mohawk is you know, ensuring they know what the guidelines are to protect themselves and when and how to doff equipment, and then ensuring they have the supply chain. So that's part of the function we're doing right now, is that we're trying to procure the stuff that they need right now, the gowns, the masks, N95s, and whatever else they determine that they may have issues with. We can try to get that locally and through the state.
Okay, that to me might be the tall pole in the tent for some, particularly some of the volunteer agencies that may not have that degree of, I won't say sophistication, but that degree of capability. So that was one that leaped out at me. I've been through that before. So yeah.
And Jared, just real fast, would be appreciated if the EMSA work with the other components of the county health system to develop protocols regarding quarantine. Right now, everything is new, and we're figuring this out as we go, and I'm sure a lot of what we're seeing throughout the country is reactionary. But from the standpoint of if an exposure occurs and people are ordered to go into quarantine, that requires the agency to do that for smaller organizations and volunteer organizations. That could greatly impede your operational response. So, you know, please communicate that up so that as they make their policies and make their decisions, we make sure that we're still able to respond to the community needs.
Through the health department DOC, the health officer is involved as well as the director of the DOC. So we'll share those concerns, because those will be definitely coming from the public health department on those recommendations or how to quarantine.
And that's being addressed at the hospital level too, right? Half the ERs on quarantine don't have an ER anymore. So.
And so there's a link through the state EMS agency that gives daily updates on COVID-19 and specific guidelines for EMS on a day-to-day basis. So I sent that to Jared, and he's distributing that to all the stakeholders, just so you have that link. But that's probably the best, most up-to-date source to go to as far as protocol recommendations from CDC and others.
Yeah.
If I could just mention a couple things from the hospital standpoint is, we are having regular county meetings with the county health department, and so the hospitals are doing a really great job in the collaboration with this. And also just know that everything that you're thinking in terms of equipment and ventilators and things like that, all of that is already underway. I can tell you, speak for our hospital, we've activated our incident command team, and I'm leading the entire operations branch for the hospital. So we look at equipment. We're working with the county to build hotlines for people to call into, that we can collaborate amongst the hospitals to run, possibly telemedicine. There are a lot of things happening in the background in the county, and I just really want to give a lot of kudos to the county health department and the 4 hospitals all together. We have a really great process, and I think moving forward, the hospitals will be operating our tents the same. We will deploy at the same time. When we do deploy the tents, that's why we kind of all have them up, and we're kind of getting them all ready. In terms of quarantine sites, we're looking at quarantine sites, just, we're looking at the prison population, the homeless population, if we kind of have big outbreaks. So there is a lot of work happening in the background. We have regular weekly county meetings all together, and so we'll keep you posted. One thing I want to say is, I'd like to talk to maybe Dr. Burley a little bit more about the whole testing component and having people test themselves. I think it's really important right now for the hospitals and the health department to work together, and the health department to be very aware of who is being tested. Because what we're trying to do is really keep tabs and mitigate spread, right? So it's important for the county health department to know who's being tested, who's coming out positive. And so the hospitals have committed at this point that all of our testing is going through the health department. So whenever we test any patients, we are going through the health department. We are not using the outside labs just yet, because we kind of want to keep that information close.
One of the limitations to the outside labs, you can't just take a swab and submit it.
Right.
It has to be collected by somebody in specific protective equipment. So the doctor's offices, most of them are not able to do that. There's only a few specific sites where it can actually be collected for submission anyways.
And most of them are saying that they're not going to collect it at the sites. So then it really leaves only one place, and that's the emergency department to get it. So the other thing is that we could have results within 8 to 18 hours or so using the health department. The outside labs, it's taken about 3 to 5 days to get results back. So that's another kind of gap there that we're kind of staying away from that.
And it's not clear who that information gets reported to.
Correct.
Or if it gets reported at all.
That's the problem. Yeah, that's the problem where we're kind of want to limit that.
And from the, go ahead,
Just
sorry.
real quick, thanks for the update. Really encouraging that the 4 hospitals are working very smoothly together. I don't know if this is happening, but would it make sense to have EMS agency representation at these meetings? Because if you're making progress and you're dealing with the kind of top to bottom issues regarding COVID-19, I think there's a lot of piggybacking that could be potentially done with the EMS agency.
And that was my segue in that we have been participating in most of these meetings, especially now, maybe not in the early stages, a month ago.
Sure.
But our commitment is to take all that, regurgitate it, because our, responsibility is for the pre-hospital environment. And so we will,
Sure.
anything that pertains to, response or policy changes or PPE was what we will be delivering the message to, so.
Great.
And I'm happy to talk to Ed Moreno and Christy, because I think it would be good to have one of you at those meetings, just to kind of hear what the hospitals are doing.
Yeah, we've attended a couple of them, that Dr. Walls, I'm sorry, is it Walls?
Oh, Craig Walls, from
Yeah.
Tivit.
So, yeah, we've been, we've got a laundry list of meetings that we're missing the launching of the health department DOC right now, because they're supposed to be initiating that as we speak, and that will be a huge area to be able to gather information, disseminate it out to the pre-hospital provider group, so.
Let me just say one thing since you brought up information. I want to caution everybody, the EOC is activated at level 3, which we announced, so that's been in place for already a week. And we also activated a joint information center for the county, and that is the mechanism that we should be using for all communication, not health-related communication, and they do it separately. We could get ourselves in a lot more trouble than if we never even formed a JIC, if the health people decide that that's their ballywag and they're not going to share that information with everybody else to coordinate. So let's just, let's all try to get on the same page with that. The Joint Information Center should contain communication professionals, whether they're PIO or otherwise, from any entity that gives messages to the public.
And I can tell you that is already happening. So Karen, the PIO from the county, and all the PIOs from the hospitals, plus infectious disease specialists and things like that, they're already having, bi-weekly joint calls, and so they're all communicating together. Again, the goal is that the messaging coming out is, we're all coming out with the same consistent message. So that's happening. Now, whether EMS needs to be a part of that, or if you all have a PIO, would be something to consider, but they're already having those
Yeah,
joint.
so my point is that if the EMS agency, for example, if part of your daily operations is to do public messaging, get somebody in that JIC, and if there's an issue, see me and I'll make sure you're in it, so that you can be included in that coordination.
I think that might be one of the missing components is the EMS representation at the Joint Information Center.
Right.
Because, yeah, the health department has their own DOC, but how is that information flowing? So we'll follow up on that and find out what mechanism we need to.
Well, from two standpoints, Jared, I totally agree with what Jerry said, having been involved in that area for some time. But there's nothing more confusing for the civilian population to get information from two different poles within the same overall county organization. So it should be consolidated. Let me add one other thing, just giving a beat here. We've got 3 controlled populations in this county, one county jail and two prisons. They had better be included in everything that we're doing, everything we're thinking about. Because you don't want to get anything started in any of those institutions because you can't send them home like a school. But they are in fact, how shall I say, isolated to begin with.
By
But
design.
you don't, that's one place you don't, it's like a ship. You don't want to get something going on a ship, okay?
Just a general question for the hospitals. Is some of the national news, we hear stories about the ability to have the testing equipment there. Is there an issue with testing capacity at this point, or is help on the way? Or?
You know, the county has a fair amount of testing kits, and they are suspecting to get more. At this point, we are not, none of the hospitals in Monterey County are doing the testing in-house. I do know Stanford is doing their own test right now, but really no plans at this point to have the actual hospitals running their own tests in this county. But I do know there's some of the bigger medical centers that are doing their own tests right now. But a health department, they have about 200 kits and they're slated to get possibly 800 more.
And they've been very responsive.
Very much so, yeah.
That's not really an issue at this point.
No, but we are, we're not, we are still looking at screening, and we're not testing everybody that comes in the door that says, I was just on a plane from LA to here, and, on a test. So we're getting, the ERs are getting an onslaught of those types of patients, and so we're screening them per the CDC guidelines, and then, if there's some, unexplained things, we might test past that. But that's a decision that we're going to the health department with, and then with the CDC and the health department is giving the hospitals guidance on who's going to test and who's not.
And are we still in a situation where Monterey County doesn't have any confirmed patients, or
Correct.
other than the ones you just came down to us a lot?
Well, my understanding is they are asymptomatic patients that are just under quarantine and are going to be tested.
So they've been tested yet?
That's actually not totally accurate. They are symptomatic patients, but they have not been confirmed or tested for coronavirus.
You can see how easy information flows along the department.
So can I ask
I won't
that?
even tell you what we heard yesterday.
Dr. Moreno just sent, a few
Yeah.
minutes ago, sent an update, and apparently they have been tested.
Yeah, I mean, I can tell you that as early as 8:30 on the call with the teams that were sent in, is that, and I don't want to, provide this information, but I've been on the daily calls and we do have crew there. The information that we were provided is that the individuals that are there were potentially exposed to the virus, but have tested negative and are asymptomatic. We were told that the people that are asymptomatic, that are testing negative, that were exposed, would be in quarantine for 14 days. Anybody that was tested as positive, that was asymptomatic, they would extend their quarantine for 21 days. So the plan today is to have our units there for 14 days. And we've also mobilized the DEMSU. These were all through the state, by the way. There's no local resources, even though one of our crews is there, is part of the state request. It's actually strike teams that came from the Port of Oakland down here.
So can I ask, Mike,
your crews that are there, they're gonna be the sole crews responding in if they do have an issue with a patient or somebody comes up positive, has the temp, starts to show signs of pneumonia, they're gonna be transporting and not an outside ALS agency coming in to run the call.
That is correct.
Okay.
And as what we were told this morning was that the likelihood that there are low acuity patients with no significant emergencies, they will likely not even be transported to facilities in Monterey County. That's what we were told.
Okay.
And all those decisions are made by EMSA or the state, so we're not even in that.
Yeah,
The information flow, to Gary's point, has been very challenging.
Well, it's changing by the minute.
It's imperative
That's what happens.
Yeah.
that we, we're all attempting to speak with one voice, but it's.
Wait 10 minutes, it'll change.
And it is changing constantly. I mean, yesterday we were notified that they were going to put up a tent city at Fort Ord, and we had all types of crews that were going to be coming in from the deployment. So it's changing by the hour.
And just I don't know if anybody else gets this, but just throw it out there. Just last night, I was contacted by 3 different news agencies for comment on what was going out, and you have to be just very careful because you know things, and the tendency is just to say what you know. And I had to say, listen, we have a joint information center in the county. I'm going to refer you to them for all interviews and comments to the media. Anything I say is off the record, and it's not official. So if any of you get approached, because they're looking for a story, and the information is evolving faster than anything I can tell you. So it's best policy just to refer them to the JIC and let the speakers that have been designated, Mayor or Karen or whoever it is, be the person that gives them the story.
Jerry, one last thing. To Dr. Burley's point, I read the CDC guidance and protocol that was put out on the EMSA website. It's very thorough, it's excellent, and this is really for the ground and air providers. It provides recommendations for everything from PPE to patient assessment to disinfecting equipment and apparatus. It's really good. So that's the focus of where we're working internally in our own department. It's all coming from that guideline.
Okay.
And that will be sent, that's what you said today?
Yes.
That will be sent today to all the providers, so as soon as I get up with this.
The media reported last week that Monterey County Health will be able to do test kits. Is that still accurate, or was that?
Well, yeah, the county received the kits last
But
Friday.
Do you have to send them out, or are they being tested in the county?
The county health department.
So they can do a 1 or 2 day turnaround?
Yeah, it's usually no more than 24 hours.
And they have their own guidelines on when they test currently, right?
The CDC
Correct,
guidelines.
it's the
So they
CDC
use
guidelines.
I want to compliment the health department website also. If you're running a business and you're looking for information to share, I'm getting information from all these different places, and it's all pretty much the same, but that one on the health department website is pretty concise, and I'm sure it's pretty much tied into the CDC one. The fonts are all the same, but it's nice to be able to go to one place and kind of get all the information. I just want to help them.
Makes it easy to
Health
cut and
department.
paste.
What's that?
Makes it easy to cut and paste.
Whatever works. The big problem on people finding information on the website is finding the right information.
Okay. Thanks, Jared. On to item B, EMCC membership.
That would be me. I am happy to report that we have received nominations for the EMCC for the parks representative from RMA, and also the city managers group. They have nominated both the primary member and an alternate. For the parks, we only got one nomination because they're a little short-staffed, so I promised to follow up with the director for a future nomination. In the memo that was included in the packet, I'm also listing the members whose term is expiring on June 30th. We've already started reaching out and making sure that we get the nominations from the groups that are supposed to nominate them. We attended the Fire Chiefs Association meeting, and at that meeting they nominated the BLS representatives. So we'll be taking those to the board. We are still working on getting alternates for some of the positions, so we will continue to reach out. I think that's it.
Okay. Thank you for reaching out to Parks. Yeah, it's nice that there's some movement there. Okay, so moving on then, Steve, I think we've got you next. AMR EMT expanded scope application.
About current events, just got a text from KION asking for information about coronavirus while we're talking about dealing with the media, so they're looking. Apparently it's fine. Anyways, the EMS agency is very pleased to notify this group that we've received an application from American Medical Response to provide EMT expanded scope services, both on their paramedic ambulances as the second crew member, as well as to put on a BLS ambulance that would be staffed with 2 EMTs trained to the EMT expanded scope level of service. The application, is it in there? Yep, there we go. The application was reviewed by the EMS agency. We used a checklist, which if you look on the left column, that's just the policy number sections that relate to what needs to be in the application. We found the application to be complete, to contain all the requested information, and so we moved on to the second phase of the application process, which is the review and approval phase. And what the last check, which you'll notice was scheduled for MAC. We brought the application to MAC this morning, and we received endorsement by MAC to move forward with approval for AMR to be an EMT expanded scope service provider. The next step will be a final determination by the director and medical director and review of AMR's training records, as well as inspection of their ambulance and equipment, and creating an agreement signed by the agency and AMR, and we'll have, as soon as possible, it looks like a BLS ambulance on the road to assist with interfacility transfers. I don't know if AMR would wish to comment at this time.
Any time frame?
That's up to when AMR is ready and we can get the inspection and agreements done.
Yeah, we have our CHP inspection tomorrow with the new vehicle, so we're all ready to roll. So basically, after the inspection and approval, we could have everything in service by tomorrow.
Tomorrow or Friday?
Tomorrow, the 12th.
Oh, okay.
Tomorrow's the 12th, right?
Yeah.
Just to note, in last year, 2019, we had over 311 transports out of county. Out of those transports that are returning, we lost close to 3,867 hours, which totals of about 322 12-hour units. So that, when I did the math, that's essentially we would lose 20 days of full deployment of these hours lost of units returning back. So that's huge for us. Majority of the transports that we did out of county were for behavioral health, or mental health, San Jose behavioral health, several to Sacramento, several to Bakersfield, and a few obviously to San Diego. So adding this BLS unit for interfacilities with 2 EMTs is going to help the system. We're adding units. We're not taking away any LS units for this. So this endorsement we got for MAC this morning is a good move forward. And like Mike said, we have prepared. We have a new ambulance for this event, for this BLS unit, and we have the BLS equipment for it. Now it's just getting it on the road and pass. So it's a good move.
Any further questions on the process? Excellent. Thank
Thanks.
you.
Is it, Steve, does it require an endorsement by this committee?
No, the policy related to approval process is at MAC for endorsement. This group, we just came and let you know what's coming.
Okay, thank you.
I've got a question. Should we maybe keep something open for next month, as everything's going to change so rapidly, about having a meeting? Because having one 2 months from now, kind of is going to change an awful lot. Because if there's policy changes that need to be voted on or stuff like that.
I think we probably going to be getting direction from the health department on meetings, so we'll keep it updated, yeah.
Policy by the county.
We're hearing from some people, you suggested for a meeting, and others are canceling meetings left and right because of the potential for exposure.
Right.
And it just, yeah, so, but
It's a good point, though. All right, so item 8, future EMCC agenda items.
I would say with the alternate destinations being considered, that needs to be one of our priorities moving forward, so we can have better placement of patients outside of the ED, and the consideration of the entire group here in the county stakeholders is imperative to do it correctly. We've overrun EDs, they're going to get overrun even worse, so how can we come up with a plan to disseminate patients appropriately outside of our traditional destination model?
Great. Definitely, it's a work in progress. Okay, anything else? So announcements, and then go to the order?
I just have one announcement. I just wanted to recognize one of our paramedics, Brian McKeon. He was nominated and was awarded the Star of Life, which he's going to be flying to Washington, D.C. to receive that award. Brian McKeon has been a medic with us for over 5 years now. He actually was off duty, and I think Will can probably speak and Ben speak to this. Off duty, had a cardiac arrest, started the CPR, ran it through, and got Ross back while he was off duty. So Will, I don't know if you have more details on that.
It's essentially what was reported to me through Silas and the Monterey Fire Department. They alerted us to that event, and we spoke with Brian, nominated him through the Star Life, and it will be recognized.
Yeah. It's something that AMR does yearly. We send a group of folks that have done something above and beyond, so to speak. A lot of our folks do that anyways every day, but we try to nominate the folks that are up in that level, and I think that's part of our leadership in recognizing our employees for a job well done, because sometimes it gets missed. So Will, Ben, Mike has actually been leading all that stuff to get it going.
Yeah, I mean, it's a really big honor, and it's not just specific to AMR that they're being honored or honored. It's actually a selection process that grew about 34,000 individuals. So it's a very select group, and I can tell you that, in my 30 years in EMS, we've probably, we've submitted names, many over the years, and I've only seen 2, with Brian being the second, actually being, selected. So it's great. It's really, something to be proud of.
That's all. Thank you.
Okay, well, the next meeting then is planned for May 13th, but as I said, that could be subject to change. Unless there's anything else, we'll go ahead and adjourn.